Hello again, everybody. Our next special population is going to look at pulmonary disease. So, our case is a 70-year-old male working as a bus driver. He's an active smoker, 40 cigarettes per day for 50 years. 5 years ago, he presented with dyspnea, productive cough with sputum, usually in the morning, and was diagnosed with chronic obstructive pulmonary disease. His medications that he's currently on to manage the disease is formoterol, which is a beta 2 agonist. So if it doesn't immediately jump to your mind, a beta 2 agonist would stimulate beta 2 adrenergic receptors. So what do beta adrenergic receptors do in the lungs? They bronchodilate. So by stimulating or causing kind of a sympathetic effect in the lungs, you get a bronchodilation. So he's taking a bronchodilator and he is on a steroid. It's the main goal of the steroid, reduce the inflammation in the area. Inflammation comes with fluid. Fluid obstructs airways. If you can decrease the amount of fluid, you should hopefully get a greater diameter of an airway. Just starting with this much information, a 70-year-old male with COPD taking medications to manage his disease, is exercise safe for this patient? So before I go into the next, couple things in his case study, let's just really quick remember what COPD is. It is a combination of emphysema, where emphysema is when you lose the elasticity of the alveoli. So think of like a stretched out balloon that isn't going to push all that air out anymore. So when you lose elasticity, the lung is less able to push its air out. The destruction in the alveoli causes these coalescence of alveoli. So you get large air-filled sacs instead of these nice little small alveolar sacs, which have a ton more surface area in a healthy lung versus kind of this big, large air sac reduces the area for gas exchange. So COPD is a combination of emphysema, but also chronic bronchitis, which is more in the upper airways, where the upper airways have a lot of mucus and inflammation, and that decreases the diameter of the airways and makes it harder to move air through them. So COPD is an obstructive disease where air gets trapped in the lung. They become barrel-chested. And for the purposes of thinking about this, now adding this exercise piece, if you have air trapped in the lung, that means that there's less kind of space for fresh oxygen to be coming in because you're just holding on to a bunch of air that has already participated in gas exchange. So the question, is it safe to exercise this patient, is likely that hopefully the warning bells that were going off in your head might have something to do with, would this patient be able to get oxygen in enough to fuel the machinery of exercise? So in the information in the case, you have some information about how severe the disease is. Because just having COPD really doesn't tell you where on the spectrum of that disease they are. So these PFTs, or pulmonary function tests, help to give you a better sense of how severe this patient's disease really is. So FEV1 is the volume of air that you can expire in the first second of exhalation. And they normally report pulmonary function tests as kind of the absolute volume, but then they give it to you as it relates to the percentage, because all of our body sizes are so different that volumes that kind of mean a lot less in pulmonary physiology. So he's getting about 40% of his total expiration volume out in the first second. And that FEV1 is giving you a sense of his flow rates. If the less air is coming out in the first second, that is evidence of obstruction, because an obstructive pulmonary disease has a hard time getting air out. the worse the flow rate, the lower the FEV1. That is actually a diagnostic criteria to show you progression of the disease. When the amount of air that's leaving in the first second goes down, the disease is getting worse. So our patient does have severe COPD because his FEV1 is just getting about 40% of his total expiratory capacity out. So we've added another layer of information. He has a lung disease. His lung disease is classified as severe. If we go down one more step, we see that they have the data on his 6-minute walk test. I know you guys have done 6-minute walk tests in Jerry. This is the normative data for COPD. The average distance walked for patients with COPD is 380 meters with a range of 160 to 600. 6-minute walk test is a very popular test in pulmonary rehab. And in cardiopulmonary generally, 6-minute walk test is often used as a surrogate for a functional capacity test. For anyone with an ex-phys major, your head is probably exploding. Like, this is not a functional capacity test. You're not pushing them to their max. You're not taking the progressive increase isn't happening, but it is still an assessment of how well they tolerate an aerobic activity. And for that reason, it's a very popular way of getting some baseline data on functional capacity, where it is truly not a functional capacity test, but in a lot of the literature around cardiac and pulmonary patients, you will use this test kind of as a surrogate for a true functional capacity test. For all of the reasons you guys probably already discussed in Jerry, the ease of administration, the ability of people to do it, the adaptability for many different patient populations. For those reasons, it can be a handy assessment, and then it has a ton of normative data to go with it. So less than 200 meters is very predictive of hospitalization and mortality in this patient population. So his 6-minute walk test is above the average at 487.4 meters. So he's in the range of typical for COPD. He is much higher than that, floor value that people kind of fall off the cliff in terms of disease progression with that 200 meters. So that gives you this added piece of information about this patient. He has severe disease, but he's still kind of moving pretty well given his diagnosis. But again, this is the figure that hopefully is coming to mind when you're being asked, is it safe for this patient to exercise? And this interdependency of these different systems of the body and the fact that the lungs are going to be responsible for bringing all of that oxygen in that the heart will pump and that will get distributed to the muscles that will ultimately go to the mitochondria and allow the production of ATP to fuel the machinery of exercise. So if we have some kind of impairment at the lungs and we can't get sufficient oxygen in, is it even safe to run the machinery of exercise? So we've already discussed in this semester, we hit on some of these respiratory mechanics things in the lecture with the ladies who are pregnant. We already know that when you exercise, you increase your minute ventilation, which is again kind of like the cardiac output of the lung system. And as you increase exercise intensity, you will first breathe deeper, you will increase tidal volume, and then you'll start to increase the frequency, especially when you get to higher exercise intensities. So we're going to be asking this patient's lungs to breathe deeper and more frequent. How do we do that? What are some of the physiological responses that help us breathe deeper and breathe faster? The first is that we have sympathetic output. And the sympathetic nervous system causes bronchodilation. If you dilate the airways, you increase the diameter and you lower the resistance to flow. So when you are exercising, you will have a larger diameter of the airway. Think back to the drugs this patient was taking. He is on a beta 2 agonist. He's actually taking medication to do the thing that exercise would do all on its own. During exercise, the physiological response of the airways will actually make it easier to get air in and get air out, because his chronic bronchitis has gunked up these passages with mucus and inflammation, but exercise will actually increase the diameter. It'll open this up, and maybe we can actually get more airflow in and out. The air that gets in the lungs has to participate in diffusion to get into the blood in order to travel all throughout the body. When we exercise, we increase the blood flow that's going through the lungs. How do we do that? How do we increase blood flow through the lungs? We already know a lot of this because we've talked about the heart, which is what's pumping all this blood. We have increased cardiac output. Our heart is just pumping more blood during exercise because of that big, huge venous return, and the strength of the contraction is getting a better ejection fraction. More blood is being delivered to the lungs during exercise. We also have a higher mean arterial pressure to drive that blood through, and we have pulmonary arterial dilation. So we're getting more blood in the lung, which is significant, especially when somebody has a compromised lung, because of this idea of VQ matching. VQ matching is looking at V being ventilation. Is the air going? Q being cardiac output. Is the air going where the blood is going? So you could think of the V as being ventilation and the Q as being perfusion. And at rest, we, on average, if you take the whole lungs and you average it all out, a healthy person is right around 1. But that's not true throughout the lung. In fact, at the top of the lung, at the very top, you have the lowest pulmonary arterial pressure, because gravity works on the liquid in our lungs just like in our bodies, and it pulls that fluid down. So we have the lowest amount of blood flow at the top of the lung. It also happens to be the area of the lung where we have the highest ventilation, because the lung is like a spring and you are pulling that spring down. So there's actually a greater negative pressure at the top of the lung than at the bottom, because the weight of the lung is pulling it open more at the top, sucking more air in. So at rest, this upper zone of the lung has way more air than blood. And then that relationship reverses when you get to the bottom of the lung, or the lower zone. You have a ton of blood down here because gravity has pulled more of that pulmonary circulation into the bottom of the blood vessels. And that also happens to be the area of the lung with the lowest amount of airflow. So at rest, we have a bunch of blood that goes through the bottom of the lung and doesn't pick up on as much oxygen because there isn't fresh air getting there, or a VQ of less than 1. When we exercise and we increase ventilation, we are going to be sending more big breaths of fresh new oxygen to the top, the middle, and the bottom, an area that typically has less ventilation. When we start taking big breaths, we're going to increase ventilation in the lower lobes of the lung. And we have this increased blood flow to the lungs because we've got this big cardiac output and pulmonary dilation that will drive more blood more uniformly through the entire lung, which means we're going to have increased blood flow at the top. So just doing exercise in all patients, pulmonary disease or not, exercise improves VQ matching. Because of the mismatch that normally happens at rest, and how by increasing ventilation and perfusion, you're going to get more universal matching of air going where blood is going, you should get better delivery of oxygen. So for these reasons, I would say, yes, we are adding a stress on the body that's going to demand a lot more oxygen of diseased lungs. But to the question, is it safe to do this? It's important to know that the physiological response to exercise does make the lung in a better position to do its job. It bronchodilates those mucus-filled airways. It sends more blood to have better diffusion, more air moving in and out as we increased minute ventilation. So while I can't guarantee that this patient will tolerate exercise, I wouldn't necessarily say that exercise is inherently unsafe or that the lungs are in a terrible position, because some of the adaptations to exercise are going to give it a bit of an advantage over its resting state. That being said, I am still concerned because this is the organ that has to bring the oxygen in, and I'm going to increase the body's demand for oxygen. So while I think it's possible this patient might tolerate exercise, I'm definitely going to want to be keeping track of how well they're doing. So what do I need to monitor with this patient to know if I'm being safe, to know if they're tolerating exercise? The first is super easy, and it's oxygen saturation. Put a little pulse ox on their finger as they're exercising and see how well they are loading their hemoglobin with oxygen. We should all be fully saturated. 98% is about normal. We can have that number go down a bit without getting into trouble because of that oxygen dissociation curve. And at higher partial pressures of oxygen, hemoglobin still wants to hold on to oxygen. That cutoff, that number that indicates we're getting into an unsafe range is 88 to 90%, because that is when you hit the linear part of the curve and patients might not be able to adequately load hemoglobin enough to deliver safe amounts of oxygen in the tissue. The only way you know that's happening is if you are monitoring their oxygen saturation. Another important thing to monitor is their dyspnea. Dyspnea is that kind of subjective feeling where you're aware of your breathing and breathing becomes difficult. So the best way that I can describe dyspnea is you've probably experienced it when you've done more intense activity, exercise, and you become aware of your breathing, and the breathing is the thing you're thinking about when you're exercising. That's kind of the feeling of dyspnea. So there are a number of different scales you can use to create a little bit more of an objectivity to the dyspnea rating. The Borg scale for dyspnea is probably one of the more common, where you give it a 1 to 10 based on their level of breathlessness. So taking recordings of their Borg is very good for monitoring safely. It can also become really handy for goal setting, because if you implement an exercise program in this patient, they may not walk longer, but they might be way less breathless. So you can show progress even if you're not getting changes in like total minutes of exercise performed or distance traveled, that kind of thing. The third thing I would monitor is signs of distress. So just kind of that subjective look that they're not doing well. For a pulmonary patient, it could be flared nostrils, increased accessory muscle activation, cyanosis, dizziness, but keeping a close eye on kind of their overall kind of facial response to exercise to let you know how they're doing. So the answer to is it safe is exercise can be safe as long as we are making sure that they're tolerating the exercise. I would say exercise is not safe if you monitor nothing, because you need to know how well they are oxygenating their body. But if you are monitoring them, you should be able to implement an exercise program safely using the feedback of their O2 sats, their dyspnea ratings, and any signs of distress to alter and change your prescription. Okay, so let's say exercise is safe, but will it benefit this patient in any way? Will it do anything for him? As you can see on the slide, the patient enters pulmonary rehab with the goal of reducing dyspnea and shortness of breath, improving mobility and quality of life. So I like at this point, normally if we're in person, to find out how many of you think exercise would help this patient. If it can we do those things? We have a goal of reducing dyspnea, shortness of breath, improving mobility and quality of life. Can we actually do that? Most people feel kind of generally good about that. Like, I don't know, exercise probably is going to do something good, right? Definitely people like the end, improving mobility and quality of life. That feels pretty intuitive of what we've learned so far. But can exercise reduce shortness of breath? Because that's listed on here as a goal of exercise, that we're going to reduce this patient's shortness of breath. This first piece is really important. There is no training effect from an exercise intervention within the lung parenchyma, the airways, or the pulmonary vasculature. The lung itself does not change in response to exercise, which is very weird because almost everything in our body changes. I'm talking about this from a young, healthy athlete to a person with COPD. There aren't training adaptations in the lung. It's largely believed to be because the lungs is really not the limiting factor to exercise performance. We have a huge reserve in our lungs. So it's not the area that's programmed to change in response to exercise because it's not the area that's limiting the exercise typically. So the number of alveoli you are born with is the number of alveoli you have. You don't get to grow new alveoli because you exercise. You don't sprout new airways because you exercise. And you don't grow new blood vessels when you exercise. This is an important one to file away, especially when you're taking a test, because if given a choice, I feel like PT students always want to pick that exercise does something. So this one can be a hard one to just take in. But it's really important that as exercise professionals, we know the limits of exercise. We don't want to oversell something and promise something that exercise cannot do. So exercise will not affect or improve this patient's disease that they are having in the lung. Again, I'm talking about the degradation of elastin, the increased mucus production. Exercise will not change those factors. So if we can't change his disease, can we change his dyspnea and his shortness of breath? Let's think through why he's dyspneic and why he's having shortness of breath. We've already talked about it from the at the level of the alveoli, but let's zoom out a little bit and think about the muscles of ventilation. So our primary muscle of inspiration is the diaphragm. And what is happening to the diaphragm in somebody with COPD who is trapping air and becomes barrel-chested? They have what's called hyperinflation. And hyperinflation is going to pull the ribs out, and because of that, it is going to flatten the diaphragm. So in a normal lung, you have this nice dome-shaped diaphragm that can flatten to increase the thoracic volume, lower the pressure, and suck air in. In the COPD lungs that are gigantic, I kind of ran out of space, the diaphragm becomes flattened and there's nowhere for it to go. The flattening of the diaphragm worsens the length-tension relationship of the diaphragm. And in chronically shortened muscles, they will change over time. You actually lose sarcomeres in series when a muscle is in a chronically shortened state. So the muscle itself has changed, and it is in a terrible position to effectively move air in. So because of that, this patient is relying much more heavily on accessory muscles to assist in inspiration. Sternocleidomastoids, scalenes, external intercostals, pec minor. These are all now kicking in during inspiration to assist, because the diaphragm, which normally does its job by itself at rest, is become ineffective. So this is going to increase the patient's subjective report of dyspnea. It's information that's going back to their brain that they're working really hard to breathe because they're using all of these extra muscles to breathe. And that's one of the things that when you're running and you feel dyspnea, part of the reason your brain is like, whoa, like I'm really working hard, is you're getting all this feedback from these extra muscles contributing to the force necessary to pull the air in. The other thing that's happening is the exhalation piece. So they're working harder on inhalation because of the ineffective diaphragm. And then when they have to get the air out, in a normal, healthy person at rest, exhalation is passive because we have all this potential energy of that elastic recoil that wants to come back down to its resting length and will push the air out without any muscular effort at all. For healthy individuals, exhalation becomes active during exercise, mainly because you want to increase the flow rate. You don't want to take the time to let air leave the lungs at the rate at which just the elastic recoil would move it out. If you can kick in your abdominal muscles primarily to help create higher positive pressure during exhalation, you can get the air out faster, which means you'll have more time for that next big breath to come in for the next inhalation. So it's normal that exhalation becomes active during exercise in healthy populations. COPDers, their exhalation is active even at rest because of all that air trapping. So they have such a lower contribution of elastic recoil because the loss of elastin, that when they go to exhale, the flow rates would be so low, they're just ineffective at getting air out. So they start to use their active muscles of exhalation, primarily the abdominal muscles, to help push that air out. So the reliance on additional muscle activation during inhalation and exhalation is likely contributing to their subjective reports of dyspnea and even their shortness of breath, because this is a lot more oxygen demand even at rest with all these extra muscles of ventilation being turned on to move air in and out. So if we're thinking always about how is exercise going to potentially affect shortness of breath and dyspnea, it's good to have our head around why they are dyspneic. So why else might they be short of breath? The process by which we bring this oxygen in and deliver it to the mitochondria is dependent on diffusion, specifically here in the pulmonary circulation. There are many lung diseases that affect diffusion, making it more difficult for oxygen to cross the alveolar membrane and get into the circulation to bind the hemoglobin to be delivered to the peripheral body. Now, we can't do anything about diffusion directly. Okay, so the barrier to diffusion in COPD is the coalescence of the alveoli decreasing the surface area. Diffusion barriers in a disease like pulmonary fibrosis is because of all the scarring that the oxygen has to move through to get into the blood. Exercise will not change those things. But we can, during exercise, get more fresh oxygen into the lung. Remember that minute ventilation is increasing. We are taking bigger breaths and we're increasing our frequency. And if we're bringing more fresh oxygen in, that will indirectly aid diffusion because you'd have a greater driving pressure of oxygen if you're getting more oxygen in. So we're having increased muscular use to move air in and out of a diseased lung, and the air that's getting in can have difficulties crossing the barrier to get into the diffusion. These are all contributing to the shortness of breath and dyspnea, which historically, somewhere around this point, someone would have asked me this question. Shouldn't all of this difficulty breathing train the muscles of ventilation? This is Arnold before and after he was trained. You can see if the overload that he put on his body to give him his gigantic muscles did that to his body. Shouldn't they be like super breathers? Shouldn't they have the strongest muscles of ventilation possible? And the short answer to that question is yes, it absolutely does. Working harder to breathe every day for every breath is absolutely going to create overload in those muscles. And a classic finding of chronic dyspnea is hypertrophy of accessory muscles. You can see here a person kicking in the accessory muscles of inhalation with every breath. The muscles are visibly larger. They have gone through hypertrophy. This prominent clavicle is a really big finding of this chronic activation of the accessory muscles, as that's kind of the anchor point for them to pull on the ribs to try to create the volume changes. So absolutely yes, increasing the difficulty of moving air in and out of your lungs will train the muscles of ventilation and cause hypertrophy. So some of the studies that have shown this have been done in healthy individuals. But when you induce an overload on the muscles of respiration, we can see increases in mitochondrial enzyme activity. And what's interesting here actually is that the response of mitochondrial enzymes is even a more robust training response than you see in peripheral muscles. So that's kind of cool. I mean, they're getting some kind of a signal that it's even more important to have this prolonged aerobic potential. There's increased antioxidants, and in general, there's a phenotypic switch where 2X go to 2A, and they start to act more and more like a slow twitch muscle fiber. So there's absolutely a training effect in the respiratory muscles. Okay, so we can't change the lung tissue, but the muscles around the lung are going to respond much like the training we've already talked about in the peripheral muscles. But still, even with this being true, these patients typically progress to ventilatory failure. Basically, the hypertrophy doesn't fix the problem. So this is a little pathophysi, but let me just put this in your mind at this point. So COPD is a disease of the lungs, and it affects how well the lungs move air in and out, obviously. But there is more to this disease, and we know that when someone has COPD, this causes a systemic inflammation, increased inflammatory mediators circulating in the blood and causing damage. We know that this causes an increased oxidative stress in the body, that the lung disease causes a systemic increase in oxidative stress. And that's specific to the disease itself. if you add in the fact that a lot of these patients continue to smoke, smoking causes systemic inflammation and oxidative stress. So a lot of times there's a double whammy going on here, that both of these things are causing this systemic inflammation. So what is the effect, especially in skeletal muscle, on chronic systemic inflammation? Within the muscle, what we see is an increased breakdown of protein and a reduction of protein synthesis. So in your skeletal muscle, your muscle is always in flux. You are always building and you are always breaking down. And when you are inactive, there's more breakdown than synthesis. When you are training, there's more synthesis than breakdown. But what these studies have found is that systemic inflammation takes that balance and shifts it towards degradation, muscle loss. It also increases apoptosis of skeletal muscle cells and stimulates autophagy, or self-eating of the cells. Put this all together, and what would happen is the response of this is that muscle function worsens over time. While there is hypertrophy, over time, the muscle function worsens. And that's seen as respiratory muscle dysfunction as the disease progresses. As the disease progresses and the ventilatory muscles are getting worse and worse at doing their job, we see that blood gases begin to worsen. They're worse at oxygenating their blood. So this systemic inflammation affects ventilatory muscle function. But what about the other muscles in the body? They suffer the same effects. The chronic systemic inflammation and increased oxidative stress breaks down skeletal muscle. And that is pulmonary cachexia. Cachexia is the wasting away or the loss of lean body mass disproportionate to caloric intake. So they're losing body mass. We see a fiber type shift and a response to the systemic inflammation towards a type 2 glycolytic phenotype. So in response to the systemic inflammation and oxidative stress, the effect in peripheral muscles is an impaired oxidative capacity, a worse ability to use oxygen and make ATP, and a greater reliance on anaerobic pathways and glycolysis. And there are studies that have shown this correlation between quadriceps strength and COPD severity. As the disease gets worse, there is greater and greater loss of peripheral muscle strength. And of course, there's a piece of this that has to do with just decreasing physical activity, but the studies would support that it's more than just a lack of activity. It's actually an active breakdown process. So there's space at the top of the next page of your notes to draw out the vicious cycle of muscle pathology in COPD. So COPD, as we just mentioned, causes inflammation and oxidative stress. The effect here on peripheral muscles, as we just described, is a reduction in type 1 muscle fibers and a worsening oxidative capacity. So I'm just going to write that as decreased type 1 and decreased oxidative capacity of the peripheral muscles. They are worse at using oxygen to make ATP. So if you're not using oxygen to make ATP, what pathways do you use? You use the anaerobic pathways, right? So with less ability to use oxygen, there is an increased reliance on anaerobic pathways. and specifically glycolysis. If you're running glycolysis a lot and not doing a lot of aerobic pathways, what are you going to begin to accumulate in the body? Well, the end product of glycolysis is pyruvate. We have to get rid of pyruvate or it's going to shut glycolysis off. We have two choices. It can become acetyl-CoA if there's oxygen available, which looks like we're not doing a great job of that because we've lost our oxidative capacity. What's the other option? Pyruvate becomes lactate. When there is this muscle fiber shift away from aerobic metabolism and there is a greater reliance on glycolysis, we see early lactic acidosis. You're accumulating lactate earlier and much more severe because you're relying heavily on glycolysis. Let's jump back into the PowerPoint for a minute and then we're going to finish this chart. How does early lactic acidosis affect the lungs? Or what does it even have to do with the lungs? Let's go back to that minute ventilation. And we said that as you increase exercise intensity, you increase the total volume of air moving in and out of the lungs. But there's this interesting change in the curve. If this was a purely linear relationship, you would expect it to continue along this green dotted line. But the curve bends right here, and it starts to exponentially increase. There's a greater effect on minute ventilation than you would expect if you just followed a linear path. And we call that bend in the curve the ventilatory threshold. The ventilatory threshold is the point at which pulmonary ventilation increases disproportionately with oxygen consumption during a graded exercise test. So if you have increased the exercise demand in a stepwise fashion, you should expect a similar increase in oxygen uptake. But when you look at it through the measurement of ventilation, when you hit the ventilatory threshold, you begin breathing more than the body's oxygen demand. So it's like an excess ventilation. Where is this excess ventilation coming from? Why are we breathing more than the oxygen that we need at high exercise intensities? It is because the lungs are not only a place to take in oxygen. The lungs serve a very important role as a buffer. The carbonic anhydrase reaction shows that when you make extra hydrogen or acid, you can eliminate that acid by breathing off more CO2. Remember, CO2 you can almost think of as an acid. And if you start breathing off CO2 and you're breathing at a higher rate than your body is making CO2, you will shift the entire anhydrase reaction to the left, and that will help pull acid out of the body. So when the patient reaches the ventilatory threshold, this is when the lungs are both acting to increase oxygen uptake as well as buffer the lactic acid. Let's go back to our vicious cycle. When COPD caused chronic inflammation that made peripheral muscles worse at using oxygen to make ATP, and it relied more on anaerobic pathways and had earlier lactic acidosis, that means that ventilatory threshold is going to be happening much earlier in the exercise intensity spectrum. This is going to increase the ventilatory requirement. I'm spelling it wrong. Ventilatory requirement. You're going to be using the lungs as a buffer earlier. Well, what will that feel like to the patient when they are having an increased demand on their lungs at lower exercise intensities? Well, it's going to feel like dyspnea. So COPD absolutely causes dyspnea directly from the changes within the lung itself. But this systemic effect on dyspnea comes from the changes in the peripheral muscles. If you're starting to feel dyspneic when you walk around the grocery store or take the stairs and you have this increased work of breathing, what's that ultimately going to do to your physical activity? It is definitely going to start making you make life choices that are going to cause you to decrease your activity. When you reduce physical activity, you're going to decrease strength. So we're going to see weakness. We're going to see greater fatigue, which all by itself is going to feed back and cause worsening activity. The weaker you get, the harder the activity is, the less you do the activity. When you reduce the aerobic demand on the muscles, you're going to worsen their oxidative capacity. So a vicious cycle is where one thing causes another, but ultimately loops back and makes the initial stimulus even worse. So the effect of COPD on peripheral muscles is going to ultimately lower activity, which makes peripheral muscles worse, and around we go. So the question was, can exercise do anything about the dyspnea? Well, we can't do anything about the effect of the lung disease causing dyspnea. But we know for sure that we can use exercise to change muscle. This is old hat, right, at this point in this semester. Can we do a targeted exercise intervention to interrupt this vicious cycle and make this patient's dyspnea better? Absolutely. This is a pretty cool study that helps to show this effect. So let's start just in the top box here. So they measured kind of the ventilatory requirement of the activity, and they put patients through an arm training. So the exercise intervention was an upper body workout. The dark green bars are the ventilatory requirement of that activity before they went through the training, and the lighter green bars are after the training. What they showed was in both arms, when you went through a training program and you repeated that same activity, that arm work, there was a lower ventilatory requirement after training. So in response to an exercise training program, there was a benefit to the lungs. But when they measured the ventilatory response to lower extremity workout after an arm training program, there was no difference in the ventilatory response. Let's look at that the opposite way. They did the same study where they trained the legs. And when they trained the legs, they showed that after training, when they did lower extremity exercise, there was a reduced ventilatory response. But when they looked at the effect when they did upper body work after a leg training, there was no effect in the lungs. So this study shows that while there might not be training adaptations in the lung itself, the peripheral use of oxygen can change the ventilatory response. Because the kind of respiratory response to the training program was only seen in the muscles that were trained, the benefit of the training program, let's say in the top box, improved the arm's oxidative capacity. It made the arm muscles better at using the peripheral oxygen, so you didn't need to drive the lungs as hard. But since there were no training adaptations in the lower extremity, you don't see the pulmonary effects. So this study shows that the training adaptations that benefit the lungs are in large part because training makes the periphery better at using oxygen. If your periphery is better at using oxygen, you don't need to drive the lungs as hard, which is a huge benefit to our pulmonary patients. This slide shows the effect on that lactate threshold before and after training. If you can make peripheral muscles better at using oxygen to make ATP or improving their oxidative capacity, you will be able to exercise at higher intensities and for longer before you begin to rely on glycolytic pathways. If you can delay when lactate begins to accumulate in the blood, you can delay when you need to use the lungs as both an oxygen delivering organ and a buffer. You can delay that ventilatory threshold in the minute ventilation that causes a disproportionate increase in ventilation over and above the oxygen demands of the muscle. So exercise can increase the type 1 phenotype. It can increase oxidative capacity. It can delay the lactic acidosis, which will reduce the ventilatory requirement of that activity, reduce the dyspnea sensation in response to activity, which will make patients more likely to be physically active, which should increase strength, decrease fatigue, and improve quality of life. We can absolutely make a huge change in these patients' lives with exercise, even though the disease itself isn't going anywhere. COPD is still going to be destroying lung tissue, but we can make their peripheral body better at using the oxygen they have. So this patient went through 3 months of pulmonary rehab where they did 3 times a week of an exercise session, 1 time per week with an educational session, and 1 time per week with psychological support. The exercise plan was a whole body endurance training. They did a combination of cycloergometry and corridor walking. They used a Borg 10 scale, 1 to 10, so they did a 3 to 4 intensity. They did both upper and lower extremity strengthening with rest allowed in between in a home exercise program. So did this exercise plan help this patient? After 3 months, the patient subjectively reports improved shortness of breath and reduced dyspnea. Their FEV1 really did not change. Their forced vital capacity increased a little, but in general, the pulmonary effects were pretty minimal, almost no effect on the FEV1 to FVC ratio. But their 6-minute walk test increased significantly. Their Borg RPE scale during the 6-minute walk test went down significantly, and their dyspnea rating went down significantly after 3 months of an exercise intervention. So while we did not change this patient's lungs, you absolutely changed this patient's life with exercise. Okay, so this video has kind of hit the golden hour here, so I'll end it here before we do our next case.